what can you do to reduce your risk of cancer, breast cancer and other cancers? So having an ideal BMI, keeping your weight within the right range after 50 is so important for risk reduction of breast cancer. Exercising, moving frequently, or at least getting your heart rate up for 20 minutes 3 times a week, and it doesn't have to be 20 minutes all in one go, is important, again, for risk reduction, not just of cancer, but of cancer recurrence if you've had it before. Smoking, absolute no-no. Drinking alcohol. We know that alcohol is a definite risk factor, again, for all cancers. And then when it comes to breast cancers, it's about our estrogen or hormone exposure. So people who take the oral contraceptive pill for a long period of time, or people who take HRT for a long period of time, can have an added risk. And if you add all of those bits of factors in, little bits and bobs, you can just imagine how you're building up your risk profile. In saying that, if someone is diagnosed and they say, why has this happened? I don't have a family history. I'm young. I don't smoke. I don't drink. I'm a vegan, etc. That's what I mean. It isn't as simple as that. Because if it was as simple as that, then we would have found a cure by now.
Welcome to the 51%, the podcast where we cut through the noise and get back to basics when it comes to women's health. Through expert insights and powerful personal stories, we help you tune into what really matters: your body, your well-being, your life. No one-size-fits-all advice, just real conversations to help you understand your health on your terms. But before we dive in, I've got a quick favor to ask. Please hit subscribe and join the 51% community on our website. It's free and helps us grow, reach more women, and create events that really speak to the health and wealth challenges we all face. And finally, just so you know, everything shared is for information only. It's not medical or financial advice, and always speak to a qualified expert for support that's right for you. Anushka, welcome to the podcast. It's great to have you on. Could you please introduce yourself and also talk a little bit about who you are, what you do, and why you do it? Thank you so much.
Of course. Thank you for having me. So my name is Anushka Chaudhry, and I work as a consultant oncoplastic breast and cosmetic surgeon in the southwest of England. I'm currently also in a management role at my trust. I'm Deputy Chief Medical Officer in charge of workforce. I have been working as a consultant for the last 11 years. I've got 2 daughters who are 13 and 16 now and are married. And I also founded and run a young women's breast cancer charity, which is in its 10th year this year. And as well as that, I'm really passionate about sharing information and education amongst ethnic minorities when it comes to breast cancer.
That's fantastic. Absolutely busy, constantly busy.
I
know, just a little bit is an understatement for sure. So, today we're going to be talking about breast cancer, and I want to understand the statistics, and from what I understand, it's kind of almost there's more chance of women getting breast cancer now. That's one thing. And also, I know it sounds silly, but what is breast cancer?
It's not a silly question at all. And you're right, unfortunately, globally, cancer rates are increasing. With regards to breast cancer, numbers are rising. So on average, about 55,000 women a year will be diagnosed with breast cancer, and 11,000 approximately may die from breast cancer. That being said, breast cancer is more treatable than ever before, and survival is much better than ever before. So the key with it is early detection. Yeah. Now, what is breast cancer? So any cancer of the body is where the cells are growing abnormally. Now, in our bodies, if a cell grows abnormally, we have certain little checkpoints in our body that get rid of bad cells. But when it comes to a cancer, the bad cells are able to get through, and they are able to grow themselves and develop their own blood supply and become their own being, basically. Unfortunately, with cancer, it will tend to, wherever it is in the body, take over the normal action of that organ or where it's supposed to be and stop that organ doing what it should. And so that's what cancer is essentially. Breast cancer, of course, is where that starts in the breast. But as a disease, if it does get out of the breast, then it can go to various organs in the body. And those main places can be your liver, your lungs, your bones. So once again, as I said, it is more treatable than ever before. And the key is about early detection, which I'm really passionate about telling women about.
Yeah, no, absolutely. What are there different types of breast cancers?
Yeah, absolutely. Great question again. So breast cancers essentially form from the kind of cells that we have in our breasts. And the cells that we have in our breasts have different functions. So the most common type is called an invasive ductal cancer. That's about 90% of breast cancers, and they grow inside the milk ducts, so where the milk travels. And believe it or not, men also have milk ducts, okay, whether they produce milk or not. The other parts of the breast are the lobules, which make the milk, and that's called a lobular cancer. And there are just under 10% of cancers. And then there are other smaller components with kind of less common ones that can form within the breasts.
Okay. I didn't know that. For when I think breast cancer, I just think of it as one thing, and that's that,
Yeah.
really.
Yeah.
Now, we know that the rates are on the increase. So I just want to go into what the risk factors are and the kind of genetic predispositions, if there are any, and what that involves.
Yeah, absolutely. So the thing is, I want to just say there is no one thing that will cause a breast cancer. Multifactorial. And I think that goes to be said with why we're having a global increase, is that undoubtedly there are environmental and lifestyle factors that we've just progressed to in the way we live, where now the Western world, which was always seen to be higher risk because of the lifestyle, is now, the Eastern world is on par with that because the lifestyle is pretty much very similar wherever we are. So when it comes to risk factors, it's easiest to always think about it in terms of what's in your control and what's out of your control. So modifiable and non-modifiable risk factors. And the things we can't control with regards to breast cancer are being female, because undoubtedly women tend to have breasts. So that's a risk factor in itself. Aging is another thing that we can't control. And in reality, about 80% of breast cancers happen from the age of 50 onwards. So, we just can't help it. That's just how it goes. The other things that we can't control are our family history. So having a family history does not mean that you've definitely got a genetic problem. Gene-related cancers only count for about 10 to 15% of all cancers. But the myth that people think is if they've got no family members, that they will never have a breast cancer. So you don't have to have a family history to get a breast cancer. Although having a family history, depending who they are in your family line, can increase your risk as well.
Yeah, I feel like, correct me if I'm wrong, it's kind of generally one in two will now get cancer, a form of cancer. And those days of thinking, we don't have cancer in our family, so it's not going to happen. It feels like one in two. Well, it sounds like it probably will at some point in your life. And that's a scary, scary thought, really. Because you literally look around, it's like one in two, that's either me or you or me, which is very, that's really scary. And I don't know, maybe I'm going slightly off topic talking about cancer in general,
Not at all.
But it feels like going from, years ago, it was like 1 in 8 or 1 in 10 or something, to now 1 in 2. I feel like something's gone fundamentally wrong with all the kind of, we're doing so much research on it now. It feels like a lot of money is being pumped into research, but now we're at 1 in 2 instead of reducing that.
Yeah, I think the key with the 1 in 2 is that we know that 1 in 2 people will be living with a diagnosis of. So I know that sounds like a weird thing to clarify, but you're right, cancers across the board, and that could be skin cancer, that could be your stomach, your bowel, your brain, your lung, any body part. So 1 in 2 of us will be living with. And the key with the living is not dying with cancer. So it's not that 50% of the population are going to be eradicated because we have cancer. The fact is all the research and the money that is being pumped into cancer research is to help be able to treat it, cure it sometimes, depending on what cancer it is. And those advancements are really helping with the fact that we are trying to catch up with the numbers that are being diagnosed with cancers across the board. and help those people who are diagnosed live as normal a life as possible. So if we were lucky in the right way with the right cancers, they may die from something completely different, not the cancer. Undoubtedly, that will affect their quality of life, your mental well-being, your emotional well-being. And so cancer isn't just a disease that affects the body, it affects every single part of you and your loved ones as well.
Yeah. I suppose, yeah, you know, you're right. As we age and as we get much older, we're kind of we potentially could get something, whatever that is, whether that's dementia or cancer, or that there is going to be something. And you can do your best to live the best lifestyle in terms of health and, you know, movement and things like that, and reducing toxins and all sorts of things. But it doesn't guarantee, there's never a guarantee that you won't get anything, you know.
Definitely. And I think people have huge guilt, or when they are diagnosed, they want a reason to why this happened. And that brings us on to the modifiable risk factors, really. So what can you do to reduce your risk of cancer, breast cancer and other cancers? And, you know, we know that when it comes to breast cancers, most breast cancers are hormonally fueled. So us women, we have high levels of estrogen in our body up until the menopause, where the estrogen is coming from our eggs, from our ovaries. After the menopause, women are still producing estrogen, and they're surprised by that, but we produce estrogen after the menopause from the fat around our bodies. So having an ideal BMI, keeping your weight within the right range after 50 is so important for risk reduction of breast cancer. So being overweight in itself is a risk factor for all cancers, but yes, breast cancer. So weight is one of them. Exercising. Now, exercise isn't realistic for everybody. Some people have chronic pain. Some people just can't get out and about. But moving frequently, or at least getting your heart rate up for 20 minutes 3 times a week, and it doesn't have to be 20 minutes all in one go, is important, again, for risk reduction, not just of cancer, but of cancer recurrence if you've had it before. Smoking, absolute no-no, increases the risk of all cancers. Drinking alcohol. So we used to say, oh, certain amounts would increase your risk. We know that alcohol is a definite risk factor, again, for all cancers. Alcohol causes reduces the body's ability to repair its DNA. That DNA, once it's damaged, remember those bad cells getting through the checkpoints. That's where we are increasing our risk when it comes to that. And then when it comes to breast cancers, it's about our estrogen or hormone exposure. So people who take the oral contraceptive pill for a long period of time, or people who take HRT for a long period of time, can have an added risk. And if you add all of those bits of factors in, little bits and bobs, you can just imagine how you're building up your risk profile. In saying that, if someone is diagnosed and they say, why has this happened? I don't have a family history. I'm young. I don't smoke. I don't drink. I'm a vegan, etc. That's what I mean. It isn't as simple as that, because if it was as simple as that, then we would have found a cure by now.
Yeah, I suppose. Yeah, that's true. I do wonder though, you know, it's been so many years. Finding a cure I'm hoping it's going to be very soon, but yeah. I think breast cancer, correct me if I'm wrong, you know, breast cancer is the #1 cancer in women.
It is, you're absolutely right. Yeah, it really is. It's the #1 cancer. And I think, you know, when you talk about cure, it is so complex because, you know, as we've alluded to, there isn't just one type of breast cancer. And what I do when someone is diagnosed, and what we and our team do, is it's not just one size fits all. Treatment is extremely individualized, and it's looking at the specific, what we call the biology of the cancer, because let's say, I'm just going to say these words, a grade 1 ductal cancer in one woman is completely different to a grade 1 ductal cancer in another woman. So yeah, I think people should know that it isn't one size fits all. And so, you know, when you're diagnosed, everyone's got a story to tell you about their experience or someone they know. It's just try and block out the noise and know that, you know, you're going to be treated as that individual.
Yeah, absolutely. I think for me now, you know, this is what I want to do with the 51% as well. It's not a one size fits all. Yes. Whatever you have, whatever you're going through, whatever you want to do, just block everything out and focus on you and what's going on with your environment, who you are and what you're about, and what, you know, whether you've got kids or other responsibilities, working 9 to 10 or whatever it is.
Yes.
Because what works for me is not going to work for you, and vice versa. You know, there may be some similarities and some resonance, but it's still going to be very, very different. And I think a lot of people are going down the route of, you know, seeing lots of things on social media and in the newspapers, wherever they get their information from, and looking at what everyone else is doing, which is fine, which is great, because sometimes you find that resonance and you feel like, I'm not alone in this journey of whatever you're struggling with. But you cannot copy what they're doing. That's the number one mistake, in my opinion, anyway.
I think that is harder now than ever before. I feel so fortunate to have grown up in an era before mobile phones and social media. At the same time, I feel fortunate that we have it, because there are so many advantages, and information gathering is there at the tip of your fingers. But I feel like exactly what you said, that, you know, a lot of the decisions we make now, I wonder how much of it is influenced. And I can tell you now, I am definitely influenced by what I see.
Yeah.
And you wonder, are your opinions or your likes your own, or is it because it's just been put in your face 24/7 and you think that you like that matcha latte that someone had because they look really good in their yoga leggings, and therefore that has got to be the thing I need to fit and meet? Or even with me, you know, working, I always say I work like 4 jobs, and that's not something I'm saying, look at me, I'm amazing way. It's I've got to go, am I doing it because I want to do it? Yes, fortunately right now. But at what point am I feeling I'm doing it to please other people? And that noise we are constantly dealing with, it's really hard. I think it's measuring success, isn't it? And I think it's the same thing when it comes to making decisions in breast cancer. Is you've got to listen to your own mind. But at the same time, information is key, because it's a new world for you where you've never explored before. And what is the noise that you do let in? That's
Yeah.
the thing that help people navigate.
Yeah, absolutely. That is key. What is the noise that you do let in? And it's difficult to find that, though, you know, find that noise that you let in, because there's so much of it. And let's not go down the kind of social media route, because I could go on about that exactly. We're going down the social media rabbit hole now. But I want to, you know, let's reel back into breast cancer now.
Yeah.
What is the best time to check your breasts for changes? You know, and what age should you start, really? Because I know there's this kind of narrative, every month you should be checking, and I'm pretty sure a lot of women forget. I forget, you know. Have you got any tips even on how you can build that into your kind of, you know, habits, I guess?
Yeah, absolutely. So I know this sounds crazy, and I don't think you should start when you're like 10 years old, but I am very passionate about going into schools and educating people on breast health. I think that is a good time when you're going through puberty to start understanding the changes that happen with your breasts. And I think it is so underappreciated how we're supposed to act like everything's normal, but it's very normal to have one breast completely different to the other. And as a teenager, you're hiding that because you don't know if you're out of the norm or not. So I go into schools and I will talk about the fact that it's very normal to be different, or talk about boys developing breast tissue and the fact that it usually goes away if we're lucky, but actually there's things you can do. So in terms of the timing of checking yourself, we're not supposed to give a solid recommendation, but from my experience, and actually I would say the right time, would not be a week before your period if you are someone who has periods. And I think any woman who does have periods, a lot of them may have quite lumpy or painful breasts about a week before, and you're going to start feeling things that aren't normally there. So it's better to let your breasts normalize, leave it till about a week after your period is a good time. Now, there's no harm setting an alarm on your mobile phone. You know, we have appointments for so many things. Make an appointment with your body and take that time to check in with yourself. And that can just be in the shower. So yeah, you could do it every day, but that seems a bit toxic and unnecessary. But whether you're putting your moisturizer on, whether you're having a shower, or you're just in your room and going, this is my few minutes of breast check, I'm going to check in. For women who don't have regular periods, or women who are after the menopause, just pick a time a month, right? So first Monday of the month, I'm going to do my breast check. And that is the time to do it. There are apps that can help remind you to check your breasts, and there is a charity called Copperfield, and they have really good resources. If you download their app, they have a kind of breast check reminder. Always a really good thing, because yeah, you're right, we have busy lives, and to check in is a good thing. And the key is not to live paranoid, but to know that it doesn't mean it's never going to be you. So why not just check yourself, and know what's normal for you? What I often find is women come for the first time ever, and they, whatever age they might be, and they say, I've seen an advert on TV, or my friend got diagnosed and I've checked and I found something. And I'll say, well, was it there before? And they go, I don't know, it's the first time I've ever checked. And that's understandable, but it's got to start somewhere. So as soon as you know the normal contours of your own body, the sooner you can then compare if something has changed consistently for you.
Yeah, no, absolutely. I do forget, and I feel like a lot of women actually forget. And putting that, I know it's a simple thing. Sometimes we don't look out beyond what's happening in our lives. But you just saying, just set a reminder. Actually, I just thought, why don't I just I've got so many reminders on my Google Calendar to do this, do that. Why don't I just add it on there? And I've never even thought to do that until you've just said that. And that's just the most simplest thing. I can't believe I didn't put two and two together myself.
This is how easy it can be. So it's not that there's no excuse, because again, that's like you're putting guilt on someone. I don't believe in that. Yeah. I just mean, it could be you, and why not just check? That just do the best for yourself. No one else is going to do it for you. And use that Google Calendar.
Yeah, absolutely.
No advertising intended.
Oh yeah, absolutely. I'm not advertising Google at all, but yeah, whatever calendar you use. Yeah, even if it's a notebook or paper calendar, whatever, just put it in there. Yeah. So I wanted to ask you, checking your breasts properly. Can you kind of talk through how that is done? Because there are lots of ways people probably do it differently, but I'm sure there's kind of one-ish way that is the right way.
Sure. Is this a visual thing, or shall I just talk through it?
Both.
I'll do both. Okay. So, there isn't one specific way, but there is a guidance. And I think that every guidance is a good thing, because then, you can say, I think I'm doing it the way I was told to. And I think one of the key things is don't grab and pinch. You're using the flats of your fingers. Because if anyone listening to this now or watching this is to grab their breast, they will undoubtedly feel something quite lumpy and go, what on earth is that? So what you're trying to do is feel, to the best of your ability, the surface and the contours. So when you're doing a breast check, use good lighting and maybe the same place every time, so that you've got one comparison against the next comparison. I would say it's like a spot the difference picture. So stand in front of the mirror and look at both breasts. Look at the contour of your chest, because you won't believe when you actually stop and look. Some of us are very uneven, even with our rib cages. And take stock of where your nipples are facing. Do they look inverted? Meaning, are they in? Are they not? And again, that can be normal. And if it's been like that forever, then don't go rushing to the hospital. And just have a look at the shape of your breasts. Then raise your arms above your head. And by doing that, it stretches up the breast and allows you to have a look underneath if you're not very big breasted. If you are, you can use the other hand to lift up and just check in. And what we're looking for there is, are there any signs of dimpling or rippling or pulling in of the skin? Now, that can happen sometimes with significant weight loss, where you start getting dimples and ripples. But again, if it's something new for you, then get it checked. Then you can put your arms down, and you can either go in a circular motion, thinking of the breast like a clock, so 12 o'clock, 1 o'clock, and just pressing, going like that. Or I like to go up and down, up and down, up and down, until I get to my armpit. So I'm pressing, and using the flats of my fingers, just pressing. When I get to the armpit, I'm actually dipping my fingers into my armpit. And the reason is, the breast isn't just a circle, it has a tail like a comet, which sits just under the edge of our muscle here. So you can pinch breast tissue. And it's quite common also in Asian women, but all women really, to have extra breast tissue in their armpits. So it can like an extra lump. And that's not abnormal, but it is breast tissue. So do check it as well, because a breast cancer can happen in that tissue. And then by pressing that tissue against your rib cage, you're really feeling, are there any lumps in my armpit? And that's where the glands are. breast cancers tend to spread to glands in the armpit if they're going to go. There are other ways they can go, but that's one of the areas. And then you're going to put your arms down and again, just take stock, have a feel of the glands just above and below your collarbone, and you're done. And it's a less than a minute exercise if you're just checking in, and, so you can either press or smooth. And that's it. That's a breast check.
That's great. Thank you. Thanks so much for going through that. I actually didn't realize starting a bit higher up, to be honest. Yeah. I didn't, I wouldn't have thought to do that. I would have just thought to start
where the round
in the breast.
You're
yeah,
right.
Exactly.
Tissue, believe it or not, can extend really high up here in the thinnest amount. So actually, even if your breasts start here, you should start higher up on the chest. It's also an area that isn't found in a mammogram. So if you're having a mammogram, which is an X-ray of the breast that compresses your breast between two plates in this direction and that direction, this area doesn't normally get picked up. So it's so important to check it yourself.
Yeah. So going on to mammograms, actually, which is something I wanted to talk about now. Yeah. I know there's an age to start that process, and you're kind of called in automatically. Correct me if I'm wrong again. Can you kind of guide me through that in terms of what age you're called in for a mammogram? Why would you be called in for a mammogram, and so on?
Yeah, absolutely. So the NHS breast screening programme will call women from the age of 50. So it doesn't mean in your 50th year you'll get called. It could be up to your 53rd year where you get called for your first mammogram. And we do a mammogram every 3 years, up until the age of 70. Now, after that, mammograms don't tend to happen unless you have checked in or you specifically need to have them. You used to be able to request them, and it will vary across the country as to whether that's the case or not now. In some countries, mammograms start from the age of 40, and I believe that is what I would love to be able to offer in this country. So I do offer that, but in the NHS, that is not on offer. And I think the reason for that is, as we said, breast cancers are becoming more common and being diagnosed with more younger women as well. So every 3 years from the age of 50, you'll get called. And I think it's really important to know that people worry about mammograms and going there and what it means and what it's like to go, but it's a quick appointment. The team currently is all female who will do your mammogram, although it's been in the press recently about having male radiographers because of a workforce crisis. So they're women. It's free to have a mammogram. You don't have to pay for it, and it's fast. And then once you've come, you get your results letter within a couple of weeks. Now, if you're having your first mammogram or any mammogram, the point of it, remember, as I said, a spot the difference thing, is to compare a picture from 1 year with a picture from another year. If it's the first one, of course, we can't do that. So you may get called back. Now, if you're called back, it's terrifying, right? But it doesn't mean we're going to find anything. It might mean that they just need to take some extra views where they do another mammogram, but maybe with a magnification. And a lot of the time, nothing else comes of it. But if it's something they're not sure about, well, hey, that's the point of the screening program, is to diagnose cancers as early as possible before you would have been able to feel them. And so you may have a biopsy.
Are there any instances where you could be called before the age of 50? Because, you say ideally it would be 40, but what if you're someone?
So if people who have a family history of breast cancer or a genetic predisposition, they may be recommended to have not only MRIs from a younger age, but also then mammograms from the age of 40 every year till the age of 50, and then into the screening program. But if you are someone who has a family history of breast cancer, you can discuss that with your GP. And, we do a family history tree, and you can fill in a family history questionnaire, which could be sent to your local genetics unit, and they would determine whether, number one, should you have increased screening or should you have a genetic test? And there will be counselling associated with that. Or you can seek that appointment yourself. You can sort that out yourself, but it is available on the NHS.
Okay. So if you have a family history, now how is that a parent, or could that be a cousin or an aunt, or how?
It could be any of them. So
anyone.
Mostly go on the basis of your mum's side, your maternal history. But even with your father's side, if there is a strong history of cancers, even on your father's side, then it could be possible that there is a genetic mutation. So, for example, the most common genes that people know about with breast cancer are the BRCA1 and BRCA2 gene. They're spelled BRCA 1 and 2. And the BRCA2 gene is one that can cause an increased chance of a man getting prostate cancer in his 40s, breast cancer, and other kind of gut type cancers. So if there's a family history of cancers that seem to just be in younger people, or a higher chance of other cancers, doesn't have to be just breast and ovarian, which are the most common we look at, then it's important to mention them.
Right.
So whilst we have the BRCA1 and 2 genes, there are actually about up to 20 different genetic mutations we can test for.
Yeah. So I just want to kind of clarify this then. If you have a family history of some sort, you should go to your GP and mention that, and they will go forward with whatever they need to go forward with.
Yes. Yeah. So if you have one family member, that doesn't significantly increase. Okay, so you're not going to qualify for genetic testing. You're not going to qualify for increased screening. Even if you have 2 members, depending on who they are, you may not qualify for it. But if it's your mum and your sister, then that's a reason to kind of speak to a GP about it. And then they can fill in a questionnaire and take it from there, basically.
Okay.
Yeah.
Okay, fine. Yeah, I just wanted to clarify that,
Yeah,
if there's anyone that's kind of has that in the family, to just kind of know what the process is. Now, going back to, if you do discover something not quite right on your breasts or under the armpit, can you walk me through what the next steps are for that person?
Yeah, absolutely. So if you find something, and let's just quickly cover, if that's okay, that the most common presentation of breast cancer in someone who's checked themselves is a lump. So 60% of women will find a lump. The other changes can be dimpling. It can be a rash on the nipple or the areola, which is the coloured part. It can be blood coming from the nipple, or new nipple inversion, your nipple dipping in, or a lump in your armpit. Okay, so those are different things that breast cancers can present with. So if you feel or find something, you get in touch with your GP and make an appointment. Best case scenario is you'll be referred to what we call a 2-week wait clinic, or a rapid access clinic. Now, that used to mean that you'd be seen within 2 weeks, and that's not necessarily the case across the country. And that is just the situation that we're in. But you will be given an appointment. You can also seek that via private health insurance, or you can self-refer to a breast specialist in the private sector. So when you come for an appointment, depending on the protocol of the hospital, you will either have imaging first or see a doctor first, depending on what age you are and what information they've had in the referral letter. You will be examined. You will have a history taken. The questions that we've gone through about the risk factors, about your age, your family history, have you had mammograms before, the pill, HRT, all of those kind of things. And then when you have your imaging, depending on your age, so if you are under 40, you may not have a mammogram. You're more likely to have an ultrasound. But don't expect that you're going to have any imaging at all, because if the doctor feels that the breast is absolutely fine, then you may not even have any imaging. I think it's important to say that, because people come with the expectation that they're definitely going to have a scan. So if you're above 40, again, you are likely to have a mammogram, maybe an ultrasound. And either way, whatever age you are, if we see something that we're not sure about, or we are sure about, we need to biopsy it to confirm it. And then if you have a biopsy taken, you go home. We don't get the results that day, but you'll have a discussion about what is felt, what is seen on imaging, and you're given an appointment to come back a couple of weeks later to go through the results of the biopsy.
Okay, and then you take it from there, whether it's positive or negative. Okay, fine. Yeah, so with that, it's kind of, if, for instance, the doctor says, I think it's fine, and you don't need, but this is kind of going down the advocacy route, and you kind of know that actually this is not right, and there have been cases of where women have been misdiagnosed, or have had to wait however long they've had to wait, and then cancers can progress quite quickly. What can you do?
Yeah.
I know obviously there's the private route, but if you haven't got the funds to go privately, I always say, try and find a company to work for that offers private healthcare these days.
Oh,
But
it's such a shame to even have to feel like that, to be honest with you. And
yeah,
just to say to everyone, it's very common that people who work in the NHS also do private work. So you might see me in one hospital or the other hospital, and I would almost treat people the same wherever they go, to be honest with you. The advocacy thing is so important. And part of that is because there is a lot of data, mostly from the US, to suggest that a Black woman will have to see her doctor about 7 times more than a white woman to be referred for a breast symptom. And that's really upsetting in itself, to know that there's an inequality depending on who you are and where you come from. And on top of that, most importantly, just to digress very quickly, is that Black women are more likely to be diagnosed younger than white women when it comes to breast cancers, with a more aggressive type. So it's easy to say, oh, you're too young to get diagnosed, but actually that is not the case anymore. So I think the key thing is, that's why I'm really so keen on people just knowing what's normal for them. So you can then say, look, I know I check myself. This is different for me. This isn't me just looking at a TV advert. I know that this is not normal for me. Now, if you're examined and it's normal, and or they say it's normal, and you'll say, but I'm sure that's different. What I would like is that people can feel strong enough to say, I would like you to then explain what I am feeling. Because even in my experience, and this isn't saying anything bad about any colleagues ever, but it's very easy to say to a patient, it's normal, you can go, when you're very busy, okay? It's normal, there's nothing there. But it's not normal because it's brought you to the clinic. So what is it you're feeling? And I like to spend time when I examine my patients to say, oh, okay, I know what you're feeling, and this is what it is. The contours of the breast do this, and you've lost some weight, so the fat above it is gone, and so you're feeling the waves a bit more. And they go, oh, right, I know exactly what you mean now. And then they know that's normal for them. But if you just dismiss someone and say it's normal, but they know it's different, that's going to cause them to come back again and again. So part of it is asking for an explanation. The other one is saying, look, if I'm really sure, then you can insist to the best of your ability that you do have some imaging. No one should refuse that, especially in this day and age. But if the doctor is genuinely convinced, we have to say, look, a healthcare professional who is experienced has examined you. And so we have to take that as face value. But if you're then sure that afterwards it is still different for you, yes, unfortunately, you should make another appointment and ask to get seen.
Yeah. Okay. No, that's fine. I just wanted to kind of clarify that as well for people, because I know, a lot of people might have issues going to get diagnosed and coming back kind of a bit deflated that they're dismissed or something like that, right? No, I just want to quickly talk about the imaging. You've got mammograms, ultrasounds, and MRIs. What are the key differences, and is there kind of the best one that you can do for your breasts?
Yeah, it's difficult, isn't it? Yeah. So they all have different uses. And when it comes to the most common breast imaging we use in the UK, it's mammograms and ultrasound scans. In the US, they use MRI a lot more. When it comes to mammograms, as I said about it, it's X-rays of the breast, so it's radiation, but very small amount of radiation. The reason the breast is compressed between 2 plates is to thin the breast out, so the rays have to travel less distance, basically, so they can get through the breast, and you can get a good picture of what the breast looks like. And then by having mammograms, you can look for various changes and patterns of changes, and things that you may not be able to feel, such as little specks of dots of white stuff, which is precancerous change that you would never be able to feel. So mammogram is really good, and we look at imaging in a way of sensitivity and specificity. So how useful is it, and how sure is it going to be when I find something? An ultrasound isn't necessarily, at the moment, although they are developing, a good tool for screening the breast. And that's why you shouldn't use an ultrasound just to go and scan somebody looking for something. It's very good at looking at a focused area. So let's say I've seen a mammogram and there's an area that looks odd to me. I reviewed that. I'm now going to ultrasound that same part of the breast and look in much more detail to say, can I get a bit more definition? So by putting the two tests together, you're getting an even more accurate image. And that's why we don't do it all the time. It's good to add in. And then MRI can be really, really helpful, especially in younger breasts where the tissue tends to be thicker and denser, or certain types of cancer. It can be really helpful. So, we talked earlier about lobular cancers, which can be about 10% of cancers. They don't necessarily present like a lump, like a ductal cancer will. They present like sheets that go through the breast tissue. So you may never feel a lump, but you could have extensive change in the breast, and an MRI is quite good for seeing that. So again, when someone is diagnosed, all hospitals in the country have what we call a multidisciplinary team meeting. In America, they call it the tumor board. So we meet once a week with our radiologists, surgeons, pathologists, oncologists, and other people in the room. And we look at every single biopsy that's been taken on the screen, like the slides. We look at all the imaging, we talk about the patient, and then we have the diagnosis. And from there, although a single clinician can make a plan, it's about being collective so that we can have everyone's best opinion to do the right thing for that specific case. And so sometimes we'll look and go, okay, the mammogram says that, the ultrasound says that, but I'm still not happy. I think I'd like to do an MRI. And so we do discuss specific cases to say what's the best thing.
I had no idea. I didn't realize that actually. I thought it was, you see one person, then you go to another person, and then that kind of thing. But it's actually, it's great that you all sit together and go through each patient, obviously hospital specific. Not obviously, you don't see
not the whole country,
around the whole of the country.
Well,
but hospital specific, you see each patient individually and collectively, because that's where it's a team thing, because there's so many people involved. And that's fantastic. I never knew that.
Yeah, I think that's part of why I find this specialty so utterly satisfying. Is it is across multiple disciplines. We're very, very collaborative. And it's amazing when you have a good team of people where, everyone's there for the same reason. We're all there for the patient. We're all there to do the best for the patient. And, for example, if the oncologist is there and they're treating someone with chemotherapy and they think it's not working, then the surgeon in the room will go, well, is this the time to start operating? Can we, or the person who gives radiotherapy might say, well, they can't operate on it, but I can give it some radiotherapy. Like, it's really, really great to be able to do that together.
Is that for all cancers or just breast cancer?
All cancers across the country have a multidisciplinary meeting, and private patients are also discussed in that setting. So there's the same standard across the board.
That's fantastic. I never knew that. No, that's great. That's actually really reassuring and great to hear, to be honest. No, it is. It's very useful information. Okay, no, that's great. So I just want to ask you the final question in terms of, I know we briefly covered kind of your preventative measures, but what, if you could kind of recommend top 3 things to do for preventative care, what would you suggest?
I think in terms of, we may not be able to prevent everything, but about risk reduction for sure, would definitely be to know your breasts and check yourself once a month so that you can advocate for yourself if you need to. The second one is the lifestyle factors, which I'm going to try and bunch up together if that's okay.
Yeah.
But I wouldn't say to anyone, you've got to completely stop drinking. It's just everything in moderation. But yes, everything we do does increase risk. So no drinking, minimal drinking if you want to, but definitely no to smoking and considering what you're putting in your mouth and your body and exercising. And then the third one, which is, I don't know if it's a preventative, but it's trying to stop scaremongers. So we were talking about the noise and what noise you let in. And in this world of social media, it is so hard to know what is true and what's not. And it's really important to me to be able to bust those myths. So don't believe everything you read. Definitely cross-check it. And just because a paper is published and available online to read, don't think that we're all capable of deciphering it and knowing what we've read. I think that's really, really important.
No, that's great. Thank you. Anushka, thank you so much for all your insights and all the information you've given. It's been fantastic.
Thank you for having me. Really enjoyed it.
Thank you.